and welcome to Round Robin. I'm your host, Robin McCormick with the City of Hampton. And today we are going to talk about a subject that some of us are a little squeamish and uncomfortable about, but it is vital to your health, and that is colorectal issues. My guests are Dr. Greg FitzHarris and nurse Nanette Sandberg. Welcome.
Thank you.
Good morning.
How do we get over this hurdle that people are just very uncomfortable talking about those body parts? You guys do it every day, right?
Right, and I guess it's one of those things where people don't like to talk about it, but certainly a vital part of your health. It's something that we use every day, something that unfortunately has a very common cancer risk, and cancer risk that you can mitigate by being screened, fortunately. So you can really reduce your risk of ever developing cancer or having any colorectal issues.
So, talk to us a little bit about colorectal cancer. There are very few symptoms until you're pretty far down the road, right?
That's a good point. As a matter of fact, the number one symptom of colorectal cancer is none, because of the fact that we screen, which is great. So if you get screened, you can pick things up before they ever cause symptoms. It's the unfortunate few people who present with, say, abdominal pain or significant bleeding or weight loss that's pretty ominous. And that tells you that this disease is probably a little far along and potentially not curable at that point. If colorectal cancer is caught early, it's curable.
So people should go for screenings, varying amounts of frequency, I think, based on risk factors, right?
Correct. If you have no risk factor for colorectal cancer, the screening guidelines now currently stay starting at age 50. However, the American Cancer Society has moved that back to 45 because we've seen an uptick in the incidence of colorectal cancer in younger populations.
Oh, wow. So how common is this cancer?
It's relatively common. If you look male versus female, men have about a 1 in 24 chance, and women about 1 in 26. So not too infrequent, and that's the reason for screening.
Wow.
Yeah, there's about 100,000 cases of colorectal cancer a year, and about 50,000 people die of this disease a year.
And is that 100,000 cases, but that means it's gotten to a certain point. So if you're screening, they can see precancerous, right? So some people don't actually develop it if they're following.
That's absolutely correct. And actually the incidence is decreasing. Except for the younger population, the incidence of colorectal cancer is decreasing in the United States. And we think that has a lot to do with the screening programs that have been instituted.
Okay, that makes sense. So what things are crucial besides, it's not just colorectal cancer, although I think that's the most common and the main one that we're talking about today, but there can be other bowel issues that you operate on.
Absolutely. As a colorectal surgeon, we specialize in treating all diseases of the lower intestine, the main ones being colon and rectal cancer.
And rectal cancer is different.
Oh, totally.
This was a newsflash to me when I had a friend who got it. I thought, I'd never heard of that before.
Right, absolutely. Even though it's part of the large bowel, it's the lower portion, but the way it's treated is different, and the workup is different, and the modalities for treatment are multidisciplinary. So it could involve radiation, could involve chemotherapy, can involve surgery. So rectal cancer in and of itself is handled differently. And actually, because of everything I just discussed, the incidence and survival has improved. So yes, it is a different animal. But in addition to colorectal cancer, colorectal surgeons take care of inflammatory bowel disease like Crohn's, ulcerative colitis, and then all the maladies that can occur around the anus. So you've got your hemorrhoids, most common thing, perirectal abscess and fistula, anal stenosis. There's a whole host of different things, even just itchy bottom, things where people have issues that other physicians either just back off or they don't even look. And that's where we come in.
So you are a surgeon, but do you also do other things than surgery?
Yes. So as a colorectal surgeon, that's what I like about the specialty. There's a lot of variety. So I work with Nanette, and we do, for example, anorectal manometry.
Oh, I have no idea what that is.
So we measure the pressures of the sphincters to check people, for example, who have problems with bowel control. That's another thing that we take care of. I forgot to mention.
And there is something you can do to fix that. That I had not known.
Oh, yeah, absolutely. As a matter of fact, it's probably one of the most common diseases that people don't like to talk about, or I shouldn't really call it a disease, it's more of a condition.
Okay.
So you have trouble controlling your bowels, and a lot of people are shut-ins. They don't go to church, they don't go to different meetings or out to visit friends because they're afraid that they're going to have an accident. And so I will evaluate a person who has that problem, and Nanette often will help in terms of working them up with the manometry, checking the pressures in the anal area. Then we will offer them different treatments, one of which is actually unique. It's called sacral nerve stimulation. And it works similar to like a pacemaker for the heart, where you have a stimulus that goes down a lead to the heart, keeps the heart beating properly. This one is similar. It has a stimulator that stimulates a nerve in the sacral area that provides continence control. And it's quite amazing. I mean, I think Nanette would attest to the fact that, you know, we have people who basically pretty much had to almost quit their jobs because they just couldn't function. And then after this procedure, we're back working and doing all the things that they like to do.
And I'm going to guess, Nanette, people are reluctant to call about this. They you know, just don't want to mention it, don't know that it's treatable, don't know that there are things they can do.
I think a lot of these patients it's emotionally challenging, and they talk to Dr. FitzHarris, and they hear, okay, there's probably a solution to this, and they hear what Dr. FitzHarris has to say, and then they kind of like almost black out or block it out. And then I meet up with them. It's sort of like, okay, now I kind of break it down for them. And I spend that time that they need to kind of talk about what to expect before surgery, during, and after surgery. And I think hearing it from a nursing perspective really helps that patient. And just having that clinical point of contact, being able to call and say, hey, Nanette, this is happening, is this okay, is great. So
I bet. So one of the things we want to do here today is get the word out that there are treatments for these, that people should not stay home embarrassed, but should really seek some treatment or some guidance or figure out what it is.
That's true. And as Nanette points out, I think it's one of those things where people are really embarrassed. I mean, sometimes I'll have folks come in and they will barely open up to me at all. And I just have to let them know, hey, it's okay. I mean, I'm used to taking care of this problem. You don't have to worry about it. And again, maybe they'll open up more to Nanette, and we work together as a team. And I think that's really important. Nurse, doctor, working together as a team to help people, it's critical. And I think our results have been phenomenal. I mean, you see people coming back a month later and just saying, my life has completely changed. It's incredible. Now, you don't always hit a complete home run. People don't necessarily go from being incontinent to perfectly continent.
Right.
But even if they're 50 to 75% better, it's can be a game changer, and they're very happy. So I feel that that's a wonderful thing to offer folks. And of course, it's like everything else in medicine. You have to be the appropriate person. It's not one size fits all.
Right.
So, but it's incredible.
Yeah, I think, you know, the one I really remember and always so happy for her was one of our patients we followed for a while, and this was an issue she really didn't talk about, and it was like, oh, by the way, I've been having this issue. And she came in very pessimistic, like, oh, this is not going to work, but I'm going to go for it, I'm going to do it. And she was the kind who was like always out going and doing things. She loved her artwork, and she loved to go dance, and then she stopped doing that. And then she came in and said, okay, I'm just going to give it a try. We did it's a stage procedure. We did the trial to see if it would work for her. And she was like amazed. She said, I can't believe that this really helped me. So it's just great to see those patients come back and they're telling us, you know, their story, and we just love seeing those outcomes.
That's amazing.
Yeah.
It is.
That and a disease like IBS, Irritable Bowel Syndrome, right? Am I getting that? People, there's different causes, there's different things, and I think it's just a lot of doctors aren't ready to investigate it, figure out what's going on, and try to treat it. It is more common than I realized.
Absolutely. IBS, it's not a surgically treated disease. I still see folks who have IBS. Oftentimes, they've been through multiple different physicians. But the etiology can range anywhere from a food allergy to even a medication. And sometimes we really can't figure out what's causing the symptoms. It can be very frustrating. Unfortunately, not a surgically correctable issue that I can help for the most part.
But if you find the cause, people can still be helped.
Oh, absolutely. Yes, yes, yes. So there are solutions for it, but again, typically medically treated.
Mm-hmm. And what other conditions do we want to talk about a little bit more in detail so people know they can be helped? Crohn's disease, is that becoming more popular, or does it just people know what it is and talk about it more?
I think inflammatory bowel disease, first of all, there are two main types. You have Crohn's, and then you have ulcerative colitis.
Okay.
Crohn's is a disease, at least from a surgical standpoint, that's not curable surgically, but surgery can come in and basically, as I like to say, sort of get a person out of the hot sun. So they're really suffering from a particular problem with the disease, and surgery can help. It won't cure, but it can help.
It can help reduce the symptoms.
It can help reduce symptoms.
Yeah.
It can fix a blockage, for example, or maybe a fistula or an infection that can otherwise not be corrected. So surgery works in tandem with medicine, and typically that person will be intimately involved with a gastroenterologist. So I will work with gastroenterologists in that regard. Ulcerative colitis, similarly, is usually treated by a gastroenterologist to the point where either their medications are failing or some complication leads toward surgery, and then surgery steps in.
Okay. What haven't I asked you about that I should ask you about?
Well, I think one of the exciting things coming up is March is Colorectal Cancer Awareness Month. I think it's important that people do get screened, and knowing that age 50 is, for average risk people, is a time to get screened. And if you look at the American Cancer Society with the new data, 45. Wow. A lot of people wonder, well, how do I get screened? The gold standard is still colonoscopy. And there are other means of screening with stool blood tests and stuff.
Oh, you hear those advertised like on TV and stuff. Do those work?
Good question. So probably the number one advertised on TV is a test that tests for both blood as well as genes that are shed by colon cancer. Oh. So if you're positive on that test, then there's some blood in your stool or you have cancer. So the unfortunate part of it is that now, so what do you do if you're positive? You have to get a colonoscopy, and then you're trying to figure out maybe that blood is just from hemorrhoids or it could be cancer. Whereas if you get a screening colonoscopy, you could pick up precancerous lesions and get them removed before you ever get to cancer.
Yeah.
Now, having said that, I mean, it's still better to get screened in some form than not at all. Not at all, correct. The best screening program is one that people will follow. And that particular test involves sending off a stool specimen in the mail and getting your results back. And you have to make sure that they are appropriately followed up. The screening is more often. It's every 3 years for that. Whereas colonoscopy, if you're average risk and you have a normal scope, it's every 10 years. So,
wow.
So a little bit different.
So it's not a horrible thing. I mean,
No.
you know, it's not the most pleasant day you'll ever spend, but it's not the worst either.
That's correct.
I think people just need to take a day off work and get it done.
I think that preparation piece that you're talking about that people dread has become a little bit better and easier for patients. You have the lower volume preps, making it a lot easier.
You don't have to drink a whole gallon anymore.
Well, usually it was 4 liters, yes, and now it's the lower volume, which is more easier for patients. I think the other misconception is that having a colonoscopy hurts. And that's not true.
Right.
I
didn't feel
again,
a thing.
the day prior is probably maybe the worst that most people dread. But overall, you know, the risk, you know, in terms of not getting it done. So we just tell patients, get your colonoscopies done.
Right, because it can be a very aggressive, fast-growing cancer, right?
Actually, not.
Oh, okay.
Most of the time it's not. That's
but
one
it
of the
can be,
that's the reason why
right?
screening works, and that's the reason you can go a 10-year interval. Because polyps take a long time to grow. They're slow growers. Now there are some people who have genetic forms of colorectal cancer where they're predisposed, and those folks, yes, the cancers can grow relatively quickly. Unfortunately, some of those folks we diagnose in their 40s send off the genetic testing, figure it out, and then we know we have to screen them more often,
frequently, right.
correct, and then check their family members. But fortunately, they're the minority of colorectal cancers.
That's good.
Yeah.
Very good. Okay, anything else?
No, I think we've
Get screened, ask questions if you're having any sort of issue.
absolutely.
Absolutely,
Yeah, and that's a good point. The issues, people think, well, I have to wait till I have a bleeding or something. No, absolutely
Don't
not.
rush to the
No.
doc. Well, some people do,
Yeah.
but a lot of people are sort of like, let me see how bad it's going to get
Right,
first
right.
before
Right.
I call.
And certainly, if you've been screened, it's comforting to know and that you don't have something bad going on. But certainly, any of those symptoms, change in bowel habits, pain, bleeding, they should be investigated.
Don't be shy.
Right.
Right, exactly.
Right. Don't sit on colon cancer.
Really?
Yeah.
That's great.
Yep.
Okay, thank you both so much.
Thanks,
You're
Robin,
welcome.
for having
Thank you.
us.
Absolutely.
Appreciate it.
Thank you.
And thank you for watching. I love the slogan, don't sit on colon cancer, and I hope you will think about it, get screened. It's not the worst thing. It is so important to your health. Getting screened can save your life. And don't hesitate to call a doctor if you're having unusual symptoms. Even if you think it's a little embarrassing, these are professionals who deal with this every day. Thanks for watching.